everyone, good afternoon. I'm Dr. Tazeen from StudyMedic, and I'm here with all of you with our RRR series, which is actually YouTube series to make your revision appropriate. So we offer you various topics about RRR series, and if you have not subscribed the YouTube channel, subscribe now and enjoy learning. And this will help you to complete your revision in a very smart way. So I welcome you all at the YouTube channel of Study Medic to have a great experience of learning. And the basic purpose before start of anything is that keep passion and determination alive for your success, and definitely you will achieve your goals. If the dedication is there, if success is there, then definitely no one can stop you from succeeding. And another important thing is that there are just very few days to exam. So keep all excuses aside and just keep in mind that you are capable and you will be able to do this. But the important thing is that you just avoid all the distractions which are actually disturbing you and they are distracting you. When we talk about antenatal care, when we talk about care in pregnancy, always keep in mind that one thing is which you should be knowing, that this is a routine antenatal care in healthy pregnancies as well as those pregnancies which are having concerns. So what I actually meant by the pregnancies which are having concerns, that can be small for gestational age, that can be RH isoimmunization, that can be multiple gestation, which is also a high risk pregnancy. So you should be knowing about all the things which are important in the antenatal care of normal pregnancy as well as high risk pregnancy. First of all, I will explain to you about the antenatal care when the RH incompatibility is there and when antibodies are there, that how you have to proceed further and what can be the care which can be offered to the female, and when the baby is at the risk of developing hemolytic disease of the newborn. First of all, always remember that the most important antibodies, they are anti-K antibodies, anti-D antibodies, and anti-C antibodies, among various other types of antibodies which are available. When we talk about anti-K antibodies, these are actually, you have to remember that they are killer antibodies. Even when they are detected, just you have to refer the patient to the fetal medicine unit. The reason is that the baby, they are more prone to develop early anemia and hemolytic disease of the newborn. So when the titer is the antibodies are there, you have to see that how is the situation, whether the father of the baby is available for testing or father is not available for testing. When the father is available for testing, you have to see that whether the father is positive, father is negative, or father, when we talk about positivity, you have to see that the father is K positive heterozygous or the father is K positive homozygous. Okay, when the father is heterozygous, then the baby is, all the babies are not at the risk of developing hemolytic disease of the newborn. So you can go further for cell-free fetal DNA. When the cell-free fetal DNA, if it is positive, then only the baby is at the risk of hemolytic disease of the newborn. You will refer the patient to the fetal medicine specialist unit. What they actually will be doing there is that they will do fetal ultrasonography, middle cerebral artery Doppler, and in utero blood transfusion if it is needed. The baby will be delivered at 37 weeks of gestation, and there are 3 bloods which are actually performed on the cord blood, and they are hemoglobin, bilirubin, and direct antiglobulin test. If the father is homozygous, then all the babies are at the risk of hemolytic disease of the newborn. So what actually you have to do at this point is that there is now no need that you will first go for for cell-free fetal DNA, and you will decide the management. You will directly refer this patient, as the baby is at the risk of hemolytic disease of the newborn, to the specialist unit, where the testing of baby will be done in form of ultrasonography, middle cerebral artery Doppler, and after delivery the cord blood hemoglobin and direct bilirubin and direct antiglobulin test will be performed. If the father is not available for testing, then non-invasive prenatal testing is available in the form of cell-free fetal DNA, which will decide your further management. If you understand this aspect of management in one type of antibodies, you will be able to understand and analyze the aspect of management in other two types as well. When we talk about anti-D antibodies, please keep in mind that anti-D antibodies less than 4, it is mild disease. 4 to 15 is that baby is having moderate risk of hemolytic disease of the newborn, and when it is more than 15, then there is severe risk of hemolytic disease of the newborn. Again, we have to see that whether father is available for testing or not. If the father is not available for testing, then you have to go for cell-free fetal DNA, which will tell us that whether if it is positive, we have to refer the patient to the fetal medicine unit, as the baby is at the risk of hemolytic disease of the newborn. And what actually we can do, that their fetal ultrasonography can be carried out, a middle cerebral artery Doppler can be done, and then in utero blood transfusion can be done. Delivery time would be 37 weeks, and after delivery cord blood hemoglobin, bilirubin and direct antiglobulin test is performed on cord blood. In the same way, when father is not available for testing, you can see that when the father is available for testing, you have to see that either the father is heterozygous positive, father is homozygous positive, and father is negative. If when the father is homozygous, then all the babies are at the risk of hemolytic disease of the newborn. And when the father is heterozygous, then you have to go for cell-free fetal DNA, okay, and that will decide your further management. Same is the situation with anti-C antibodies. Less than 7.5 is mild risk of hemolytic disease of the newborn. 7.5 to 20 international units per ml is moderate risk of hemolytic disease of newborn, and more than 20 is severe risk. Again, you have to see when the father is available, have a look that whether father is heterozygous positive, homozygous positive, or negative. All homozygous babies are at the risk of hemolytic disease of the newborn. Heterozygous babies, you have to go for cell-free fetal DNA to decide your further management. And when the father is not available for testing, then you can do non-invasive prenatal testing that can help you in the management of these pregnancies, which is important to understand. Another important aspect of antenatal care is actually the patient reduced fetal movement, that how you have to go about. If we get a question there that 32 weeks first episode of reduced fetal movement patient, she is coming to you, so what would be the management option? So first of all, you should know that what is the stepwise management of reduced fetal movement, which can help you to understand that how you have to take it further up. So here the options are reassure, detailed history of the patient, and biophysical profile. So first of all, always remember the most important thing is that you have to inquire from your patient about the history, about the risk factors, that what the risk factors can be there, what the significant points are there in the history, which can help you to understand that what actually the reduced fetal movement is. So here the answer would be B, that you have to go for detailed history before jumping to the management options, whether you need to plan the delivery of the patient or you can reassure the patient. Before that, it is important that you have to find out the risk factors for that, which is actually important. So this is a beautiful chart which is actually describing the management of reduced fetal movement. So first of all, remember that any patient who is coming to you with reduced fetal movement, you have to keep in mind that first you have to see that whether it is first presentation or she is coming multiple times, or these are the recurrent episodes of reduced fetal movement. Then detailed history of the patient is important. You have to find out that what the risk factors are there. Okay, whether there is history of stillbirth, there is history of small for gestational age or fetal growth retardation. That is actually a significant impact, that if the patient she is having reduced fetal movement, how you can help. Now history will confirm that whether the patient is having reduced fetal movement or she is not having any reduced fetal movement. If there is no reduced fetal movement confirmed on the history, you can offer to auscultate the fetal hearts to the patient. You can do the routine antenatal assessment. You can give advice for further episodes of reduced fetal movement. And if the patient is unsure whether the fetal movements are reduced, focus on the fetal movements. You can advise them that they have to lie down on left lateral and they have to count the fetal movements, and if the fetal movements are more than 10 in 2 hours, you can reassure your patient, and if they are less than 10 movements in the 2 hours, then they can report to their healthcare provider. In the same way, when the history confirms that this is a reduced fetal movement, then the first step is auscultation of fetal hearts by handheld Doppler. This is the first step. If the fetal hearts are not audible on auscultation, then you have to go for immediate ultrasonography to rule out intrauterine fetal demise. If on ultrasonography it is intrauterine fetal demise, you will manage as the unit protocols are there. But if this is if the scan is normal, then you can, what you have to see on the scan, that you have to see amniotic fluid volume. Abdominal circumference should be assessed in the patient, estimated fetal weight, and then you will, if the patient she continues with reduced fetal movement, you have to find out that whether other risk factors like small for gestational age or stillbirth is there. If no other risk factors are there, and then you have to reassure your patient, you have to see that what actually the gestational age is, and then you can, after ruling out all the risk factors, you have to give advice that if there is any further episode of reduced fetal movement, she can come back to you. She has to focus on the fetal movement for 2 hours. Okay, and then if they do not feel more than 10 movements in the 2 hours, then they can contact their maternity unit. And when the fetal hearts are there on auscultation, then you have to do the cardiotocography to exclude the imminent fetal compromise. If the CTG or cardiotocography is suspicious or pathological, which is falling under amber or red zones, then you have to see that what are actually the unit protocols for that patient, and then you have to proceed in that way. Okay, this is how it is important, that how you have to proceed further for the management of reduced fetal movement, which is important. So remember that handheld Doppler is first step which you have to keep in mind. Okay, if there are any concerns that you are unable to auscultate the fetal hearts on handheld Doppler, then you have to proceed further, which would be ultrasonography. But if the fetal hearts are audible on handheld Doppler, then your next step would be cardiotocography. Okay, so here you are going for ultrasonography. Here, if the fetal hearts are there on handheld Doppler, you are going for cardiotocography, and based upon the categorization of cardiotocography, your further management will depend. And this is very, very important. So you should have an idea about the stepwise approach, that if a patient is coming to you with reduced fetal movement, how you have to take it up. Another important thing is about NTD administration in pregnancy. So what you actually have to do, if the gestational age is less than 12 weeks and vaginal bleeding is there associated with severe pain, okay, If there is evacuation of retained products of conception surgically or instrumentation of the uterus is done, medical or surgical termination of pregnancy, ectopic or molar pregnancy, you have to administer 250 international units of NTD within 72 hours. Always remember that if it is less than 12 weeks of gestation and it is spontaneous miscarriage, then NTD is not needed. When the gestational age is 12 to 20 weeks, for any potentially sensitizing event, you can administer 250 international units NTD immunoglobulins within 72 hours of the event. You can confirm that before giving any injection to the mother, the patient's safety is important, so you have to confirm the product, the dose, the expiry date, and the patient ID, which is very, very important. Gestational age 20 weeks to term. Then for any potentially sensitizing event, if it is taking place, you have to give her NTD, as well as you have to do the fetal-maternal hemorrhage quantification, and that can be done by you can request a Clehor test, and you can administer at least 500 international units NTD within 72 hours, and the more dose if it is needed depending upon the quantification of fetal-maternal hemorrhage, that more dose can be administered to the patient. For routine antenatal NTD prophylaxis, actually you can take blood sample to confirm the group and cross group of the patient, and then what actually you can do, that 1500 international units a single dose can be given to the patient, or you can give it in divided doses at 28 and 34 weeks of gestation, which is important. At the time of delivery, if the baby's group is confirmed as Rh positive and mother is negative, so you can request a Clehor test, and you can administer at least 500 international units NTD within 72 hours of delivery. Again, you have to keep in mind the patient's safety by checking the product, by checking the expiry date, by checking the ID of the patient, and then you will proceed further. Okay, if any further dose is needed after fetal-maternal hemorrhage tests are available for quantification of fetal-maternal hemorrhage, then you can give further dose to the patient. That is important. When we talk about multiple gestation, it is considered as high risk pregnancy, and in monochorionic pregnancies, the babies are at the risk of developing twin transfusion syndrome. The staging of twin transfusion syndrome is very, very important as far as your exam is concerned. So let's discuss one question and then let's learn the staging of twin transfusion syndrome, which can be frequently asked exam tested area. A patient is coming to you, monochorionic diamniotic twin. One liquor is 1 centimeter, twin 2 liquor is 9 centimeter, bladder is visible for both. So what is actually the diagnosis? So here actually first they are asking you the diagnosis, then they can also ask you about the staging, that whether it is stage 1, stage 2 or stage 3. So here it is actually twin transfusion syndrome. The answer would be B. But you should be able to know the Quantro classification system of twin transfusion syndrome, in which it is further divided into 5 stages. Stage 1 is that there is discrepancy in amniotic fluid volume and oligohydramnios and maximum vertical pool of less than 2 centimeter in one sac, and polyhydramnios in other sac where the vertical pool should be greater than 8 centimeter. The bladder of the donor twin is visible and the Doppler studies are normal. So normal Doppler, visible bladder, only amniotic fluid discrepancies of less than 2 in one sac and more than 8 in other sac, that is known as stage 1. When the bladder of the twin is not visible during length of examination, usually around 1 hour, but Doppler studies are not critically abnormal, that is known as stage 2. And when we say that now the Doppler studies are critically abnormal in either twin, they are abnormal Doppler findings or reverse and diastolic flow is there. So this is actually stage 3 when the Doppler studies are critically abnormal in the twin gestation. So you have to keep that in mind, that this can be reverse flow, this can be absent and diastolic flow, and there can be reverse flow in the ductus venosus, or pulsatile umbilical venous flow can also be there. In cases of stage 4, ascites would be there, pericardial or pleural effusion can be there, scalp edema or overt hydrops can also be present in this situation, which you have to keep in mind. And in case of stage 5, one or both babies are dead. Either there can be intrauterine fetal demise of one twin, or there can be intrauterine fetal demise of second twin. So the Cointreau classification basically says that stage 1 amniotic fluid abnormalities with normal Doppler and visible bladder. Stage 2 says that the bladder of the twin is not visible, however, the Doppler is not critically affected. Stage 3 says that the Doppler studies are critically affected. So that is stage 3, whether it can be abnormal flow, it can be reverse flow. Stage 4 says that there is a hydrops of one fetus, or that can be ascites, pericardial or pleural effusion, scalp edema, or overt hydrops can be present in any of the fetuses. And stage 5 says that actually this is the intrauterine fetal demise is of one twin or both. So it is actually, the staging is according to the worsening of the situation, that how the situation is worsened and how this is staging up of the disease, which you have to keep in mind. Then twin transfusion syndrome, as we discussed about all these stages of the disease, but one thing is important to remember, that it can be associated with 15% of monochorionic pregnancies, which can be there in cases of twin transfusion syndrome. Other thing is that you know that these are the stages, which can be stage 1, which can be stage 2, which can be stage 3, stage 4, and stage 5. Twin anemia polycythemia sequence can be present in 2% of uncomplicated monochorionic diamniotic pregnancies, and up to 13% of monochorionic twin pregnancies after laser ablation. There can be signs of fetal anemia in the donor and polycythemia in the recipient without significant oligohydramnios and polyhydramnios being present. Donor has increased middle cerebral artery Doppler peak systolic velocity, which is more than 1.5 multiples of the normal median, and recipient has decreased monochorionic peak systolic velocity, which can be less than 1 multiples of the normal median. Small for gestational age can also be there, which is the growth discordance of more than 20%, approximately 10 to 15% of monochorionic pregnancies. Growth discordance but positive diastolic velocities in both fetal umbilical arteries are there. When we say that it is stage 2 small for gestational stage 2 growth retardation in cases of twin pregnancies, basically this is growth discordance with absent or reverse and diastolic velocities in one or both the fetuses. And stage 3 is basically growth discordance with cyclical umbilical artery diastolic waveforms, positive followed by absent, then reverse and diastolic flow in a cyclical pattern over several minutes. It can be intermittent, it can be absent or reverse and diastolic volume. So these things you have to keep in mind. And then it can be trap sequence as well. So trap sequence is 1% of monochorionic pregnancies. So it can be a cardiac twin with usually no cardiac tissues being perfused by the anatomically normal pump twin through a large artery anastomosis on the placental surface. So twin transfusion syndrome, twin anemia polycythemia sequence, then small for this growth retardation in the twins when the growth discordance is there, and you should have an idea that what actually the growth discordance, you will say that this is significant, which is 20%, and it is approximately present in 10 to 15% of pregnancies. And then there comes twin reverse anemia polycythemia sequence, which can be present in 1% of monochorionic pregnancies. Again, timing of delivery in twin gestation is very important. So those monochorionic pregnancies which are treated with twin transfusion syndrome, the timing of delivery is 34 to 36 plus 6 weeks of gestation. That if it is type 1 growth retardation, then the timing of delivery is 34 to 36. Type 2 growth retardation, if it is there, if it is stage 2, then the delivery time is 32 weeks. If it is stage 3 growth retardation in cases of multiple pregnancy, then it is 32 weeks. Uncomplicated monochorionic diamniotic twins, it is 36 weeks. Okay, and monochorionic monoamniotic pregnancies, 32 to 34 weeks. And in case of monochorionic monoamniotic pregnancies, you have to go for lower segment cesarean section as well, which is important to remember. Another important aspect of exam is small for gestational age. So you should have a very clear idea that what are the minor risk factors, what are the major risk factors, and what would be the monitoring of the patient. So a question says that 41-year-old priming gravida smoker came at 16 weeks of gestation, showed her worries regarding chances of having small gestational age baby, and as her friend, she recently had a very small baby. So what you will advise to this patient? Now first thing is that you have to find out that what actually the risk factors are there, which you have to keep in mind. Small for gestational age baby in her friend is not a risk factor, but her age is a major risk factor here, which is 41 years of age. Although smoking is also a risk factor, but number of cigarettes is not being mentioned here. So being age more than 41 years of age, so here the answer would be serial growth assessment of the patient you have to do from 26 to 28 weeks in all those patients where the major risk factor is present. So you will do the umbilical artery Doppler and growth scans in these patients which are presenting with major risk factors, and only one major risk factor is there. You will do this, and this serial growth monitoring, it is done from 26 to 28 weeks of gestation. So here this is a beautiful chart which is actually explaining you that what the minor risk factors are and how you have to do the monitoring. The minor risk factors are maternal age equal to or more than 35 years of age, nulliparity, BMI of the patient less than 20, body mass of index of the patient which can be 25 to 29.9, smokers 1 to 10 cigarettes per day. Now here it is important that age 35 and smoking 1 to 10 cigarettes is a minor risk factor, but if the age of the patient is more than 40 and smoking is more than 11 cigarettes, then it becomes a major risk factor. Okay, pre-eclampsia, pregnancy interval less than 6 months, pregnancy interval more than 30 months, and paternal small for gestational age. All these things are important to know that whether the minor risk factors are there or the major risk factors are there. What actually comprises of major risk factors? They are maternal age, as I already told you that it should be more than 40, then smoking more than 11 cigarettes per day, cocaine abuse, daily vigorous exercises, previous small for gestational age baby, previous stillbirth, then maternal small for gestational age, chronic hypertension, diabetes and vascular disease, renal impairment, antiphospholipid syndrome, then heavy bleeding similar to the menses, preeclampsia, severe pregnancy-induced hypertension if it is there, then low maternal weight and pregnancy-associated plasma protein if it is less than zero point 0.4, you have to remember that this is actually a major risk factor. Other situations can be that if you are unable to find out the same physiofundal height in the patient, that is also important, which you have to keep in mind. Okay, so if the three or more risk factors are there, you have to do the uterine artery Doppler at 20 to 24 weeks of gestation. Okay, if it is normal, you will do the assessment of fetal size and umbilical artery Doppler in third trimester. And if it is abnormal, you will do the serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks of gestation. Okay, so this is actually about minor risk factors. When the major risk factors are there, you have to keep in mind that in cases of major risk factors, what you actually you have to see that you have to reassess at 20 weeks that if there is abnormal Down syndrome screening markers were there or fetal echogenic bobble is there. These are the soft ultrasound markers which can tell you that some problem is there. Only in presence of one major risk factor, you will do the serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks of gestation. From 26 to 28 weeks of gestation, you will do the assessment in the form of serial umbilical artery Doppler. You will reassess during the third trimester. You will institute serial assessments of fetal size, umbilical artery Doppler, if severe pregnancy induced hypertension is there, if preeclampsia is there, if unexplained antepartum hemorrhage is there, then also you have to keep in mind. So the presence of minor risk factors, the presence of major risk factors, and how you have to do the monitoring, that is very, very important when we talk about small for gestational age. Now, when you are actually monitoring a pregnancy, first of all, remember that symphysiofundal height is important in case of small for gestational age when it is less than 10th centile or serial measurements indicate that IUGR is there or the patient is having high risk pregnancy for small for gestational age based upon the history, biochemistry or uterine artery Doppler. You will assess the fetal biometry, single abdominal circumference or estimated fetal weight less than 10th centile. It will tell you that serial measurements are indicative of small for gestational age or fetal growth retardation. So if the fetal biometry, first symphysiofundal height and high risk factors, then fetal biometry, and now comes umbilical artery Doppler. This umbilical artery Doppler, when you will do the serial assessment with umbilical artery Doppler, it will tell you that whether it is normal, it is abnormal, or it is absent or reverse. When the flow is normal, you have to repeat the ultrasound fortnightly. Okay, umbilical artery Doppler, middle cerebral artery Doppler, abdominal circumference and estimated fetal weight. Delivery time, you can deliver her at 37 weeks of gestation. If it is static growth, then you can deliver her after 34 weeks of gestation. Okay, if the middle cerebral artery pulsatility index is less than 5th centile, or if it is static growth for 3 to 4 weeks, you can deliver her after 34 weeks. Steroid if delivery is by cesarean section. When the umbilical artery Doppler pulsatility index or resistance index is more than 2 standard deviation and end diastolic flow is present, you have to keep in mind that you have to repeat the scan, and this scan would be repeated on weekly basis, abdominal circumference and estimated fetal weight for biometry, and twice weekly you will be doing the umbilical artery Doppler. Okay, delivery time you have to consider at 37 weeks of gestation. If static growth is there, you can deliver after 34 weeks, and steroids as according to the guidelines of RCOG. Okay, so then there comes the absent or reverse flow. When the absent flow is there, When the reverse flow is there, you have to assess the fetal biometry, abdominal circumference, and estimated fetal weight on weekly basis. You will do the umbilical artery Doppler and ductus venosus Doppler on daily basis. Recommended delivery time is 32 weeks. You have to consider delivery at 30 to 32 weeks when ductus venosus Doppler is normal. Recommend delivery before 32 weeks if after steroids, if the ductus venosus Doppler is normal, if cardiotocography is abnormal, but the gestational age for the baby should be more than 24 weeks of gestation and estimated fetal weight more than 500 grams, then you can go about. So all these are exam tested areas. Your first steps in physiofundal height and history based high risk categorization of pregnancy, fetal biometry, okay, then umbilical artery Doppler, that what you will do if it is normal, what you will do when pulsatility index or resistance index is more than 2 standard deviation, and what you will do if it is absent or reverse, which you have to keep in mind. Then there are certain differences that the abnormal gut herniation, if it is at 10 weeks of gestation and it shows herniation of gut, you have to remember that up till 12 weeks of gestation it can be physiological as well, but if it is beyond this gestational age, then it can be sub abnormality as well. So here at 10 weeks of gestation it is actually physiological, but you should be aware that there are certain differences between ex-omphalos and gastroschisis. Ex-omphalos is membrane covered herniation of contents, smooth line, smooth outline is smooth, while gastroschisis is not membrane covered and free floating bowel loops are there, irregular outline is there. Umbilical cord is inserted at the apex of the sac, while in gastroschisis herniation is lateral, usually to the right of the cord insertion. Very high incidence of associated abnormalities and genetic syndromes is there in ex-omphalos, whereas relatively low incidence of other abnormalities is there. High incidence of chromosomal abnormalities and karyotyping should be offered, whereas there is no increase in the incidence of chromosomal abnormalities in cases of gastroschisis. It can contain stomach, liver, and spleen. Usually only small bowel is extra abdominally. Ex-omphalos is associated with polyhydramnios, whereas gastroschisis it is associated with oligohydramnios. So these differences, the risk of associated abnormalities, genetic syndromes, karyotypic abnormalities, that is more in ex-omphalos. It is associated with polyhydramnios, whereas when we talk about gastroschisis, it is oligohydramnios. The risk of anomalies is less, and it is actually a lateral herniation of the cord insertion, which you have to keep in mind. Then there comes placenta previa, that it can be there how if it is diagnosed in early pregnancy. So what would be the follow-up of placenta previa, which you have to keep in mind, that if it is diagnosed at a mid-pregnancy scan, you have to repeat the scan at 32 weeks of gestation, and you have to see that what is the situation. If it is away more than 20 away from the os, this is a normal pregnancy, you will take it up further as a normal. If it is asymptomatic, then the delivery steroid time is 34 to 36 weeks of gestation, and you can deliver the patient at 36 to 37 weeks of gestation. If the recurrent hemorrhages are there in case of placenta previa, then what actually you will do, that steroid time you have to give before 24 weeks of gestation, and cesarean delivery at 34 to 36 weeks of gestation. And if it is asymptomatic low-lying placenta, you will repeat the scan at 36 weeks of gestation to again see that what actually the situation is. If it is still low-lying, for individualized decision should be done for the patient, that how you have to go about. Okay, so this is important to keep in mind about placenta previa. Then there comes vasa previa, which is a vessel running in the free placental membrane. Prevalence is 1 in 1200 to 15,000. Fetal mortality is 60%. It can be type 1, which is filamentous insertion, type 2 connecting to the succinturate lobe. Classical presentation is Ben-Kisser's hemorrhage. No universal screening is available. Ultrasonography at anomaly scan has highest accuracy. Transabdominal and transvaginal scans both have diagnostic accuracy. If it is diagnosed, 20% can resolve till time of delivery. If it is stillbirth, then histopathological examination can be confirmatory. Prophylactic hospitalization is done in these patients at 30 to 32 weeks of gestation, corticosteroid at 32 weeks, and elective lower segment cesarean section at 34 to 36 weeks of gestation is done in these patients who are presenting with placenta previa. So this is about antenatal care of RRR series. So I hope you will enjoy the session. Always keep in mind that you are the key to your success, and you can do it by persistence, by getting along, by confidence, by organization, and by resilience. I wish you all the very best for your upcoming exams.